Hello, this is Desiree Chappell. It's Tuesday. Welcome to the Roundtable, where we have in-depth conversation with the experts as well as those on the front lines of perioperative care.
Top Bed Talk.
I'm here with my co-host, Professor Monty Mythen, Editor-in-Chief. Hello, Monty. How are you?
Hi, Desiree. Good, thank you.
Good. And we also have Dr. Liam Brennan, President of the Royal College of Anaesthetists, as well as Professor Paul Miles. He's the Director and Department of Anesthesia and Perioperative Medicine at the Alfred Hospital and Monash University from Melbourne, Australia. Gentlemen, thank you so much for joining us and sitting down this afternoon.
Great to be here.
Good. Well, it's been a wonderful day on this first day of Anesthesia 2018, the inaugural meeting. And we're just wanting to sit down and talk to you a little bit about this international perspective on anesthesia and perioperative care that you guys started the conference with today. Can you give us a little bit about what you were speaking on, and what your thoughts are on how the day was? Dr. Liam, Dr. Brennan, we'll start with you.
Okay, so I'm delighted to be hosting this conference today on behalf of the Royal College of Anaesthetists. So I started the day by talking a little bit about the college and how we have progressed in the past 70 years. It's the 70th anniversary of the birth of the National Health Service here in the UK, our national health delivery service for all UK citizens that is free at the point of delivery, that we're incredibly proud of. And anaesthesia has a huge amount to thank the NHS for in its development. It's provided the vehicle by which we have grown as a specialty and become a coherent specialty. It's allowed us to do many of the quality improvement and research studies that we perform on behalf of the college and behalf of the specialty. And I talked something about those, and I know that perioperative medicine is absolutely crucial to that agenda, and Paul and I really shared those thoughts in both our talks this morning.
Yeah, so I was really delighted to follow Liam's presentation this morning. I was asked, in fact, probably challenged is a better word, to actually give an international perspective of what perioperative medicine is and how it might relate to both the aims of the Royal College here in the UK and what's happening in our part of the world, Australia and New Zealand, of course in the US and other parts of the world. And what struck me really was, in fact, the concerns that anaesthetists or anaesthesiologists have all around the world are very common. There's a common series of themes around the fact that we've got an ageing population. They have a lot of comorbidity. They're having now more and more extensive and major operations. And our figures and results are really quite fantastic. But of course we can always do better. There are avoidable complications that can be better managed. And for that to work properly, we need more multidisciplinary team-based care. The anaesthetist or anesthesiologist has got a lot of experience in dealing with that type of complexity. We already work as teams in the operating room. We've got to sort of spread that out right from the early preoperative period right through to full recovery in the days and weeks after surgery.
So, Paul, you were very flattering in your talk about suggesting that whatever it means, it's not a competition, but the Royal College of Anaesthetists has been leading the way in the more recent adoption of perioperative medicine in the broadest sense, whereas I think we would very much look to you in Australia and your department in particular as being some of the leaders of perioperative medicine. Now, it's very flattering of you, but what prompted you to say that apart from the invitation?
I hope, and I do believe I was being quite genuine about that. I mean, I personally, I think our department back in Melbourne has sensed that perioperative medicine is the future of our specialty. But for us to be viable or competent perioperative physicians, we need to have stronger foundations in the education, training, and also research around perioperative medicine. So that's, I think, something that we've had at a more personal level, and we've built up, I think, a fantastic postgraduate training program for that. But that aside, I think in part because of the wonderful NHS system here in the UK, and the college has been working with government and the other colleges to really try and work together to come up with new ways or better ways of dealing with the management of patients through the whole surgical experience. And I think that kind of national public-focused efforts led by the Royal College here in the UK has been groundbreaking. It really has paved the way for that.
So, sorry I know you're going to come in on this, but because I want to praise your presidency, you inherited this in its developing form, and I think if we reflect back at the beginning of your presidency, you're just coming to the end of your period as president now. We seem to have gone from a degree of scepticism mixed in with what we inherited from the wonderful J.P. Van Bassel through to what feels like certainty about this in the future. Sorry, you were going to say.
And I think that's right. And I was so pleased today in one of our keynote addresses was from Dr. Steve Powis, Professor Steve Powis, who is the NHS medical director for the whole of England, so the most senior doctor responsible for the health service in England. And he praised the development of perioperative medicine specifically in his talk today. And I was incredibly proud to hear him saying that it is now starting to become part of the vocabulary of senior decision makers and politicians in this country. So I think we're beyond the tipping point now. I think we are well beyond the visionary phase. We are now into implementation, and it is now gathering pace.
Yeah. One of the things I was looking at too as we look down the schedule and reflecting on some of the different presentations today, we're really going over the elements of those global kind of ideas about anesthesia care and perioperative medicine and how those relate to everyone. And Paul, you kind of mentioned that before, how some of these topics are very relatable. When we talk about curriculum and teaching these things, Dr. Brennan, when we interviewed you back at the ASA and you were talking about how we have outreach to other providers in other countries, what is the college doing for outreach and curriculum for those particular providers?
So outside of the UK,
Mm-hmm.
So we've now got a global partnership program that is in its infancy. We are doing a lot already. We're doing some work in developed world countries, in Hong Kong and in Iceland, to build that infrastructure in education, learning, and around perioperative medicine. But also in the developing world, in low and middle income countries, we're doing work in sub-Saharan Africa, particularly around East Africa, in Zambia in particular, where we are starting to build that to meet the vision of what perioperative medicine means for local needs. It will be different from the spectrum of disease that we see here in the UK and Australia and the US. It's not going to be around the obese population. It's not going to be around the consequences of alcohol and cigarette misuse. It is going to be around some more fundamental issues around infectious disease and how we manage those issues. So making it more fit for purpose and adaptable, I think, is the challenge.
So, Paul, on that subject, there's often a question, most of the world is not getting access to the type of healthcare we regard as relatively normal. Has this perioperative medicine agenda got anything to offer, the global challenge for access to healthcare? Because I know there have been some developments in relatively less well-resourced countries.
Well, I think it does really. I mean, some of the key principles of what good perioperative medicine would be, things like teamwork, things having shared understanding, things that avoiding gaps in care that might otherwise happen with a fragmented healthcare system. So those principles, I think, are universal, and they don't cost much money. It's really about just the way we work, the way we're trained. And if we do that in a fairly coherent way in all parts of the world, then in fact everybody, and certainly the patients we care for, will have better outcomes.
Do you think some of those countries might get well ahead of us in actually being able to, in them starting off their journey of the better provision of surgery care, jump ahead to what looks like a fully developed perioperative medicine model, because they won't have the sea anchor of our traditional care practices? Yes,
I mean, I think the word disruption was used today, which I think is a really good phrase, where we as specialists are often caught up in the old paradigms of care, the silos of care and so on. We have to break some of those down, retrain ourselves, and of course pass it on to the junior trainees who are coming now as specialists. In systems where they've got little such parochial specialties, who are actually really trying to do the bare minimum as best they can with few resources, already are working very well together to problem solve and come up with the best care they can as a team. So I think there's great opportunity there for them to actually get ahead much quicker.
So one of the points I made in my talk this morning was that the birth of the NHS gave parity of esteem for anaesthetists in this country. I think for many of the low and middle income countries, they are still at that point or even earlier where there are very few physician anaesthesiologists, and we need to raise that. We need to raise the numbers of those practicing in those areas. But once they're there, and the ones already there, have got to be given the same esteem and regard as alongside their surgical colleagues. That's going to be essential to developing this team approach that we all think is essential to perioperative medicine.
Can you remind us about that, Liam? Because the history of that is very interesting, because we got right close to the wire, as I understand, in the formation of the NHS.
Sure.
And there was a potential for us being part of the surgery team, not an independent profession right at that moment.
Sure. So post-war, 1948, just after the Second World War, we had a socialist government came into power in this country, and their vision was that we would have a national health service free at the point of delivery, and I think it was visionary at that time that to be essential to that all doctors working within the service should have parity of esteem. And anaesthetists were raised overnight from being a second-class citizen, if you like, within the hospital infrastructure to being on a par with their surgical and their physicianly colleagues. And that was a quantum leap for the specialty in this country, and that was reflected in how we developed initially as a faculty of anaesthetists and then subsequently as a college and as a Royal College. And for that we are incredibly grateful in this 70th year.
How did that happen elsewhere? Do you know, Paul? Did it just you followed suit? I'm not suggesting that we were leading the way, but...
Yeah, well, I mean, that's a really interesting point, really. I think that sense, sort of more egalitarian sense that was embedded in the NHS from the start, I think certainly not just helped our specialty, but I think improved, respect for all the players involved in the care of a surgical patient. I guess it's one of the reasons why perioperative medicine has worked very well in the UK system. Australia's got a sort of a hybrid system. It also has a national health scheme, but a higher amount of private practice medicine within the country. And of course other parts of the world, particularly North America, it's even more so. So these features are there, but what I think was really right there at the start with the NHS was around public service, public good. The centre was healthcare for the population. That wasn't the case in traditional areas of medicine elsewhere. It was often doctor-focused and there was hierarchical systems. I think where we are now with perioperative medicine is, again, everyone's talking about patient-centred care, team-based care, but for some parts of the world that's been a harder change to move into than perhaps in the UK system.
Yeah, that's a great point. I think that trying to develop leadership within the perioperative medicine model and having anesthesia to lead that is good, but making sure you're still staying aware that it is a team approach, and everyone involved is as important as the others.
It is, Desiree. It is a team approach. It's not anesthesiologists dominating it. Yeah. It's orchestrating it.
Yeah.
I think that's where we see our role. I think we're the ideal people to do that because we have that overview of what's happening for the patient, and we truly do see that bigger picture, and it does allow us to orchestrate and to bring those different expertise to bear when the patient requires it. We're not going to do it all as anesthesiologists. When we need a specialist physician to advise on a kidney problem or a cardiac problem, that's when we get our specialist colleagues involved. But we can orchestrate it, and actually we can, with our expertise, deliver the majority of it ourselves.
Yeah. One person, I can't remember who was, making a point about that being part of education in anesthesia is actually how to lead the team and how to be in that, because I think that maybe is not necessarily always discussed or approach that there are different ways to lead change management, which is part of that perioperative model as well.
And we were delighted at the end of today to have the keynote lecture, the rank lecture, being given by Professor Jennifer Weller from Auckland, where she talked about just that. How do we build teams? How do we break down that silo working so that we do what's right for that person at the centre of the care in the operating room, which is the patient?
Yeah. So not only do we lead care, but we lead the team to come together and help them break. Well, one more question, just highlights from today. Dr. Brennan, what was one of your highlights?
Well, I'm going to take something slightly different from today, and that was the discussion that we had with an inspirational figure here in the UK called Claire Gerarda, and we talked about the issues surrounding wellness, around stress, burnout, and the mental health issues that we know are all too prevalent in healthcare and amongst anaesthetists, anesthesiologists, and her perspectives about how we need to do better to try and improve the lot of our colleagues, how we need to help each other, how we need to recognise that and support each other. Yes, it does need to be about system-wide solutions, but we need to do better at supporting each other within the teams in which we work.
Yeah, we actually were fortunate enough to have Claire on the podcast and tell a little bit about what her experiences are and provide resources, for us practitioners out there.
Before we get to that with Paul on that, we were discussing the fact that from the college's perspective, if anyone has a problem that relates to addiction, for example, there's absolutely no problem at all putting your hand up and saying, help me.
There's absolutely no problem in doing that.
It's a must-do.
It is a must-do. It's a must-do for you as an individual. It's a must-do for your patients as well. Of course it is. And I think the barriers to that are starting to break down. The stigma is breaking down. I think by us talking about it, by us putting this on a Top Med talk, will help people. And I know you've done that previously, Monty. And I heard the inspirational talk you had from one of your colleagues
Paul
in the US.
Wishma, we were reflecting
Paul, it was great. And I think the more we talk about it, we need to say there's no shame in this. We're human. And we have the same frailties and the same problems as any of the other members of the patients that we treat. We can be patients ourselves, and we need to be open to that.
And if you speak out on behalf of a colleague or you point out a possible issues, you're not whistleblowing and getting them into trouble.
No.
You're looking after their well-being.
No, you're not. And there are confidential programs. The practitioner health program that Claire leads in the UK is an ideal opportunity to be able to seek help.
So I cut you off on your highlights, Paul. Desiree was asking you about.
Oh, yes. Well, I was really delighted to be wedged between both Lee and Brendan's talk this morning, which is really a reflection on what the college has achieved really in these last number of years, which was so wonderful to hear myself, let alone I think for the audience. And also, of course, the medical director of the NHS talking about his vision of where the NHS should be going to and what needs to kind of, I guess, evolve. And I guess what struck me about both those presentations was this sense of engagement with the providers of the funding of healthcare in the UK system. Of course, it's the NHS, it's the government, of course, but it might be private payers in other health systems. And it's about us explaining our value, where we can actually make things better in a way that's actually for the good of patient care. So I really, for me, that was really the rewarding part of the day.
Yeah. Great. Well, any other final thoughts or things that you're looking forward to for tomorrow on day 2?
So looking forward to a second day, some more inspirational talks and a great audience and a packed house of 350 delegates.
It's been great. The program's been absolutely fantastic and participants as well.
I'll give a big plug for clinical research. I think that's what really drives better understanding of what we should do and how to do it better. And if that's built into the health system, I think we'll all be better for it.
I'm going to give a plug for Top Med Talk. We've had about 400 downloads so far today, so we've effectively virtually doubled your numbers. We're just pushing on to 25,000 downloads in total in 83 countries. I just think this way of sharing thoughts with the world at little or no expense to the individuals is a big plus. Thanks for doing it.
Certainly the way forward, Monty. Thank you.
Well done.
Gentlemen, thank you so much for sitting down with us this afternoon, and we look forward to day 2 of Anesthesia 2018. Thanks so much.
Thank you.
Thank you.
Top Med Talk. Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website edpom.org/meetings. Our next big event is EdPom USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. edpom.org/meetings.